Hi, this is Dr. Mimi Lamb from Case Western Reserve University Medical School, and I would like to explain to you the basics of 3 types of renal replacement therapy, or RRT, that are commonly used. This video runs just under 30 minutes, and as with any textbook or article, remember that it doesn't have to be viewed all in one sitting. In this overview, we'll be talking about 3 methods of RRT: hemodialysis, continuous veno-venous hemofiltration, or CVVH, and continuous veno-venous hemodiafiltration, or CVVH-DF. There are some subcategories and variations and combinations of these, but these are the basic ones that you need to understand. For each modality, we'll talk about the physiology and go over a schematic diagram of the process, then look at a basic drawing of the machine involved, and finally at a picture of the actual machine, so you'll have several opportunities to get familiar with each of these processes. So let's start with some basic terms that describe the mechanisms by which fluid and solute can be transported with renal replacement therapy. First, diffusion is the movement of solute across a semi-permeable membrane down its concentration gradient. Notice here that only the solute molecules move, not water. Ultrafiltration is the movement of plasma water across a semi-permeable membrane driven by a pressure gradient across the membrane. Here, notice that the thing that makes the water move is the pressure gradient, as opposed to solute moving because of a concentration gradient. And finally, convection is the movement of solute dissolved in plasma water across a semi-permeable membrane. As the plasma is ultrafiltered, the dissolved solute is carried along by what's called solvent drag. This forcible pressure-driven mechanism is also more effective than diffusion for moving so-called middle molecules, molecular weight 500 to 60,000, which may be of some interest in certain disease processes. However, for the processes that we are generally talking about here, we're mainly interested in the really small molecules like creatinine, molecular weight 113, sodium 23, urea 62, and so on. Now, how do these 3 types of fluid and solute movements apply to the basic types of renal replacement therapy? With hemodialysis, the patient's blood is circulated past a semi-permeable membrane with dialysate solution on the other side. Plasma composition is altered by diffusion of molecules down their concentration gradients to or from the dialysate solution. Plasma volume, as we'll see, can be decreased by ultrafiltration, and HD is performed in sessions that typically last from 2 to 4 hours. Here's a diagram of how hemodialysis works. Here's the semi-permeable membrane with the patient's blood on one side and the dialysate solution on the other side. The membrane contains many tiny pores which hold back larger elements like blood cells and proteins, but allow the small molecules to pass through. The dialysate solution contains low to 0 concentrations of solutes that travel down their concentration gradient and are removed, like potassium, BUN, and creatinine, and higher than normal concentrations of substances that need to be added to the patient's plasma, like bicarbonate. Solutes that do not need to change much in concentration during dialysis, like sodium and calcium, are present in the dialysate at physiologic concentrations, so they don't move much. So in other words, essentially what HD accomplishes is, in a given volume of plasma that contains both water and solutes, depicted here as blue and red dots, the solutes move down their concentration gradient from the plasma into the dialysate, which is then discarded, and so the concentration of solutes decreases in the patient's blood. Although the very first dialysis membranes were flat and about the size of a coffee table, current dialyzers achieve more surface area in a compact space by being made in the form of capillary-like hollow fibers with fenestrations along their entire length. the patient's blood flows through the capillaries, of which there are about 10,000 contained in an airtight cartridge. Dialysate solution flows through the cartridge, but outside the fibers, picking up the bad stuff by diffusion and carrying it away. However, the other concern in treating patients whose kidneys don't work is that you not only have to get rid of waste products like BUN and creatinine, but you also need to remove volume. The way this is accomplished is via ultrafiltration and convection. Since the dialysis cartridge is a vacuum canister, fluid can be removed simply by applying negative pressure to the space outside the capillaries, causing plasma water and all the solutes dissolved in it to be pulled through the capillary pores and added to the dialysate, which is then discarded. So the ultimate result of pulling plasma out of the capillaries is that by this process, you lose volume, but you don't change the concentrations of any of these small molecules because they are simply dragged through the pores along with the plasma water as UF and convection occur. And so what does hemodialysis accomplish? Well, as we've seen, blood circulates through fenestrated capillaries surrounded by dialysate solution. Plasma composition is altered by diffusion of solute through the capillaries and into the dialysate solution, which is then discarded. And plasma volume can be decreased by ultrafiltration in amounts as high as 1 liter per hour or maybe even more. And thus, by a combination of diffusion and ultrafiltration, a patient's blood can be cleaned and their extracellular fluid volume can be reduced as needed. But as you might imagine, removing 1 liter per hour of plasma for several hours can put quite a strain on a person's cardiovascular system. And if you're removing 3 to 4 liters in a treatment, remember that this is approximately the entire plasma volume of a 70-kilogram man, and the fluid removed from the vascular compartment needs to be replaced by refilling from the interstitial compartment. Many acutely ill patients who may have heart failure and or low blood pressure to begin with are unable to tolerate this rate of fluid removal. And for that reason, in 1977, continuous rather than intermittent methods of renal replacement therapy were first developed that essentially spread the procedure of dialysis over 24 hours instead of doing it all in 4. Today, the main methods of continuous RRT, or CRRT, that we use are called CVVH and CVVH-DF, and we'll look at a brief description of each. We'll start with CVVH. So in continuous veno-venous hemofiltration, venous blood is circulated at a slow rate through a hemofilter consisting of hundreds of semi-permeable capillary fibers, just like a dialyzer but smaller. Negative external pressure can be used to create a gradient across those capillary fibers that allows plasma water to be ultrafiltered and removed, dragging solute with it via convection, just like with HD. But the ultrafiltered plasma water, which contains all its usual small solutes like sodium, creatinine, urea, and calcium, is then replaced by a fluid similar to dialysate. And ultimately, solute and fluid balance can be altered slowly by this combination of ultrafiltration, convection, and replacement. So here's our diagram of CVVH. Over the course of 24 hours, many liters of plasma water are removed at the rate of something like 1 liter per hour, and they're replaced with urea and creatinine-free solution. Thus, solute and fluid balance are potentially altered by a combination of ultrafiltration and convection, with replacement of fluid volume essentially negating the ultrafiltration. So remember that as you do UF of those large amounts of plasma water and replace it with equivalent volumes of clean, toxin-free fluid, you still do have the ability to alter volume as well. If you want to decrease an unstable hypotensive patient's volume a little at a time, all you do is adjust the balance between the UF volume and the replacement volume. So in 1 hour, remove 1 liter, but replace it with 950 cc's. And over 24 hours, that hourly negative balance of minus 50 cc's translates to 1200 cc's per day, and so on. Next, let's look at continuous veno-venous hemodiafiltration, or CVVH-DF. Here, hemofiltration occurs just as we described for CVVH, but the hemofilter capillaries also have dialysate flowing by, which allows extra molecules of toxic stuff to sneak across the capillary membranes at each pass. In other words, toxins are lost by 2 mechanisms with this modality. 1, ultrafiltration and convection of large amounts of plasma water and replacement with toxin-free dialysate, and 2, diffusion of molecules down their concentration gradient into the dialysate, resulting in a double whammy decrease in unwanted solutes. Thus, ultimately, plasma composition and volume can be altered by a combination of ultrafiltration, convection, replacement, and diffusion. Now, let's look at a diagram and an actual photo of the setup for each of these 3 procedures. In hemodialysis, the patient's blood flows through the capillaries of the hollow fiber dialyzer in this direction. Meanwhile, dialysate flows through the dialyzer cartridge, bathing the capillaries with metabolic waste products diffusing out of the plasma into the dialysate to be discarded. Note that the dialysate flows in the opposite direction from the patient's blood. This maximizes the concentration gradient between plasma and dialysate as much as possible along the length of the capillary. In other words, if blood and dialysate traveled in the same direction down the dialyzer capillary fibers, by the time the blood had traveled the length of the capillary, much of its urea and creatinine would have diffused into the dialysate, so the concentration gradient would not be as good for diffusion. Having dialysate flow in the opposite direction allows the partly cleaned blood at the end of the capillary to meet fresh dialysate with 0 urea and creatinine, thus allowing efficient diffusion to continue. Remember that ultrafiltration can also be employed by adding negative pressure to the airtight dialysis cartridge and pulling plasma water and the solutes dissolved in it through the capillary pores to reduce the patient's extracellular volume. Hemodialysis is typically performed in 2 to 4 hour sessions. So here is an actual dialysis machine, and you can see the patient's blood flowing through the dialysis cartridge in this direction from the red end to the blue end. Its flow rate controlled by a roller pump, with the cartridge being here on the actual machine. The dialysate flows in the opposite direction and is continuously discarded down the drain after a single pass. The screen of the dialysis machine shows such data as the patient's most recent vital signs, the patient's blood flow rate, here 450 mLs per minute, and the amount of ultrafiltrate to be removed from the patient during the session, here 3.7 liters in 4 hours, with 2,638 cc's already removed and an hour and 15 minutes remaining in the session. Note that with both acute dialysis and CVVH, typically a dual lumen venous catheter is used for vascular access, so the blood lines to and from the patient are actually both venous blood, but they're labeled arterial and venous so that we can be sure they are hooked up in the correct direction to the dialyzer, and also so that we know which line is returning blood to the patient, because that's the one we want to put our meds into, like EPO, vitamin D, and antibiotics, so that they won't immediately be removed by dialysis. Now let's look at CVVH. Here, the patient's blood again flows through a hollow fiber hemofilter, which is similar to a dialysis cartridge but a little smaller, since the blood flows needed for this 24-hour procedure are lower than those needed for a 4-hour dialysis. Negative pressure is applied to pull plasma water and solutes off by ultrafiltration and convection. The ultrafiltered plasma is collected in large bags and measured, and is replaced with dialysate-like fluid, which can be infused into the blood circuit either before or after the filter, or both. Replacement fluid is essentially the same as dialysate, containing little or none of the solutes to be removed from the patient's blood, such as creatinine, urea, phosphate, and potassium. It contains higher concentrations of solutes to be added from the fluid to the patient's blood, such as bicarbonate, and normal concentrations of solutes that don't usually change much during CVVH, such as sodium, chloride, and calcium. And of course, no cells, large proteins, or other large molecules are either removed or replaced in CVVH. And remember that the patient's extracellular volume is altered simply by adjusting the balance between the volume of fluid pulled off by ultrafiltration and returned as replacement fluid. And now let's look at the second type of CRRT commonly used, which is CVVH-DF, continuous veno-venous hemodiafiltration, which is simply a combination of CVVH and a little bit of dialysis. Here the patient's blood passes through the hemofilter and large amounts of ultrafiltrate are removed and then replaced with creatinine and urea-free replacement fluid, just like with CVVH. But now the blood in the hemofilter is also bathed by dialysate solution, which enhances solute removal by using diffusion in addition to the convection that is already happening with CVVH. So here's how a CVVH machine looks. Again, we have the patient's blood running through the hemofilter at a rate controlled by the roller pump. Ultrafiltrate is being collected in one bag. This is what's being sucked out of the capillaries as they go through the canister. And notice how this bag is plasma colored, unlike these other bags that are simply mixtures of water and electrolytes. The replacement fluid, meanwhile, which is 2 of these bags, is being instilled both before the filter in the blood circuit and after the filter. And if you're adding the dialysis component in CVVH-DF, dialysate is also infused through the canister, so it flows past the fibers to pick up more molecules. And so the effluent in this bag is going to contain not only the ultrafiltered fluid that was sucked through the capillaries, but the used dialysate, which now contains the molecules of stuff picked up by diffusion as it flows past the capillaries. The screen at the top of the machine lays it all out schematically, so let's look at that. And so here we see the blood flowing at a rate of 200 mL per minute through the hemofilter, with effluent being pulled off at a high rate, which is a combination of ultrafiltered fluid that's being sucked through the capillary fibers and any used dialysate that's flowing out of the cartridge, with replacement fluid being added both before and after the filter, usually both, in quantities similar to the total effluent rate, but usually a little less because you're usually needing the patient to be in negative fluid balance with this hemodynamically friendly method of pulling off a little fluid at a time, 24/7. So we'll end by summarizing and comparing the 3 different modalities of RRT that are most commonly used, comparing them with each other and with our own native kidneys. And before doing that, let's remind ourselves what our own kidneys actually do. And what kind of things do our own kidneys do? Well, we have 2 million nephrons working together, and the first thing they do is they create a lot of ultrafiltrate, about 6 liters per hour or 150 liters per day. This comes through these 2 million sets of glomerular capillaries that create the ultrafiltrate and send it down into the proximal tubules, where it can then start to travel down through the nephron, and as it goes, it's gradually transformed from plasma into urine by processes such as reabsorption, which pulls more stuff out of the tubule and returns it to the surrounding capillaries, or secretion, which can pull stuff from the capillaries and add it to the stuff in the tubules, where it then is eventually added to the urine. And what kind of things get reabsorbed and secreted? Well, we reabsorb something like 99+% of sodium chloride and water, which are vital components of ECF that we wouldn't want to lose as we filter this 150 liters per day. We also reabsorb about 100% of our filtered bicarbonate, which is our vital buffer. We reabsorb about 50% of urea and 0% of creatinine. These are metabolic waste products that we wanted to get rid of anyway, so they pretty much stay in the tubules and enter the urine. And we can secrete additional stuff like potassium and hydrogen ion from the capillaries into the filtrate as needed to increase its excretion in the urine. And the ultimate result is that the urine output is going to be something like 1 to 2 liters per day most of the time. And this is created, remember, from 150 liters of glomerular filtrate that is gradually processed by secretion and reabsorption. Now for our comparison of the 3 artificial modalities of RRT: hemodialysis, CVVH, and CVVH-DF. Hemo employs diffusion plus minus ultrafiltration. CVVH uses convection, and CVVH-DF uses ultrafiltration, convection, and diffusion. So notice that the blood flow rates of the 2 continuous therapies are lower than for a 4-hour dialysis where you're trying to get everything done in a short time. The dialysate flow rates are also a lot lower with the continuous therapies. With CVVH, there is no dialysis, it's all convection and replacement. But even with CVVH-DF, very low dialysate flow rate compared to hemodialysis because, again, you're spreading this out over 24/7 instead of doing it all in a short period of time. Notice that with hemodialysis, you can pull off 1 to 2 liters of fluid per hour net for short periods of time. But CVVH and CVVH-DF can remove several liters per hour every hour of the day. But that's because they replace the volume that's pulled off so that the patient does not become intravascularly volume depleted or experience large swings in blood pressure. So the net fluid removal per day is about the same in all 3 therapies, but it's accomplished in 24 hours instead of 4 with the continuous therapies. Notice the clearance of small molecules in both types of continuous therapy are about the same, even though CVVH uses convection only and CVVH-DF employs convection and diffusion. The reason for these equal clearances is that small molecules diffuse readily across the membrane so that they're very efficiently moved either by diffusion or convection. However, remember that middle molecule solutes, those in the range of 500 to 60,000 molecular weight, are less efficiently removed by diffusion than by convection. So CVVH and CVVH-DF are better at removing them. And the reason that this is important is that recent studies have identified about 140 so-called uremic toxins that accumulate in renal failure, with an increasing number of these falling into that middle molecule range. Other potentially pathogenic middle molecules that have been shown to be cleared with the convective therapies include various cytokines, chemokines, myocardial depressant factors, and proteins involved in complement activation, all of which could play a role in patients with sepsis, inflammation, and heart failure. So the factors that we take into consideration when deciding upon which modality of RRT is the best to use for a particular patient includes things like these. If the patient has an unstable hemodynamic or volume status or is at risk for cerebral edema, the slow continuous modalities are safer and are much better tolerated than a 4-hour hemodialysis, which may induce wide swings in volume, blood pressure, and osmolality, or rapid shifts between body fluid compartments. On the other hand, if the patient is extremely catabolic or hyperkalemic, the rapid removal of solute by dialysis may be needed, and CVVH may not be fast or efficient enough. And if middle molecule clearance is desired, CVVH or CVVH-DF is the treatment of choice. And in the end, notice that none of these RRT methods, including the best that we have, CVVH-DF, is anywhere near as amazing as our own kidneys, which possess the ability to not only ultrafilter, but also to secrete and reabsorb substances, something that no machine can do. Our own kidneys process enormous amounts of blood, 1,000 to 1,200 mLs per minute all day long, and can ultrafilter 150 plus liters per day and clear toxins without needing liters and liters of either dialysate or replacement fluid, because they can simply reclaim what they need from the ultrafiltrate via tubular reabsorption, such as sodium, chloride, glucose, calcium, water, etc., while allowing toxins to travel on down the nephron to be excreted. Real kidneys can also boost the excretion of toxins and other stuff by secreting stuff into the nephron and to the tubules to augment what's already there because of filtration. Our own kidneys also can get rid of middle molecules and yet unidentified uremic toxins, and they can maintain near perfect fluid and electrolyte balance on their own, readjusting hour by hour without anyone doing calculations or programming numbers into a machine. And while the latest RRT techniques are very time-consuming, equipment-heavy, and expensive, our own kidneys sit quietly in their retroperitoneal space and do their work 24/7 for free. So I hope that now you can understand the basic physiology of the types of RRT, but that you will always appreciate how much more wonderful our own kidneys are than anything that even the very smartest human has been able to design or build. And so that's the end of this video, and I hope you realize that if this was given as a lecture, there would of course be multiple points that we would stop, ask for questions, call for clarifications, and so on, and you don't have the opportunity to do that here. So please feel free, if there's something that confuses you, to email questions or corrections or comments to me at this email address. And I hope you've learned something from this and that you can help me revise future versions to make it a little better. And thank you very much for watching this.